In order to avoid the kinds of icebergs that would cause a decrease in the number of years that we spend in good health, we have to first be able to see those icebergs. And in this episode, we'll be specifically continuing our conversation about tools that can identify early metabolic dysfunction in order to be able to reverse those findings before chronic disease takes hold. In the next couple episodes, we'll go over cardiovascular preventative tests and fitness-related tests. So if you want to stay tuned for those, please do hit the subscribe button and the bell icon. As always, none of the following is medical advice, so please always consult your doctor before making any health decisions. And with that, let's jump into it. In the last episode, we went over some key tools that are insulin-based and glucose-based metrics to identify early signs of insulin resistance. In this episode, we'll go over more broadly metabolic dysfunction. Metabolic dysfunction accelerates aging, and it accelerates the time it takes to develop chronic disease. And it's common enough in most industrialized nations that it's starting to affect a little more than 1 out of every 3 people. So let's continue our discussion of identifying it early, starting with lipid-carrying particles. We talked in our last episode about how the ratio of triglycerides to HDL particles could be used to identify early insulin resistance. It turns out, in fact, that there is an even better test that's slightly more sophisticated, looking at particle counts and sizes that can identify early insulin resistance, and that is called LP-IR, the lipoprotein insulin resistance index. So LP-IR specifically looks at the particle counts and subtypes and sizes of VLDL particles, LDL particles, and HDL particles. Now remember that VLDL are a major triglyceride carrying particle. LDL contribute to plaque formation in the arterial walls, and HDL particles are involved in reverse cholesterol transport and can help to clean up some of that mess of plaque formation in the arterial walls, transporting cholesterol back to the liver. Now let's talk about why LP-IR works to identify early insulin resistance. When the liver becomes insulin resistant, it ramps up its production of fat or fatty acids. That's through a couple different pathways. One of them is called de novo lipogenesis. It has to have a place to put those fatty acids, so it packages them into a form called triglycerides, where you end up with 3 fatty acids and a glycerol backbone, and then it packages those into VLDL particles, which are essentially large containers for triglycerides, and then ships them out into the bloodstream. So that's why triglycerides go up in insulin resistance. Now, with all those triglyceride-rich VLDL particles floating around, the triglycerides have to have a place to go. So they get shipped off through a transporter called CETP, and they get offloaded to HDL particles. That's not the best news for HDL particles, because when they accept triglycerides, they get trimmed down by an enzyme called hepatic lipase. That makes them have a shorter lifespan, and it makes them persist for less time in the bloodstream. So that's why triglycerides go up in insulin resistance and HDL particles go down in insulin resistance. Now remember that those HDL particles are ones that we would like to have around for a while because they help to clean up the artery wall. But in addition to being cleared more rapidly, their cholesterol efflux capacity also goes down. Now, what about the LDL particles? Remember, these are the ones that contribute to plaque formation in the arterial walls. Well, those also accept some triglycerides from the VLDL particles, but paradoxically, when those get trimmed down, they persist for longer in the bloodstream. So you end up with this pattern in insulin resistance. We have more small, dense LDL particles floating around for longer, and that contributes to plaque formation. So the way LP-IR comes into all of this is it looks at the aftermath of the downstream effect of insulin resistance in the liver, and the way that hepatic de novo lipogenesis and increasing triglycerides, decreasing HDLs, and increasing effectively the small dense LDL particles in the bloodstream. So all of these changes in insulin resistance get captured into this single metric called LP-IR. Now, traditionally, an LP-IR index of less than 45 is considered ideal. Unfortunately, when we start to make efforts to decrease insulin resistance through diet and lifestyle and exercise, that LP-IR score does come down, and that's good because LP-IR is actually quite predictive of future disease states. Now, our next test is related to insulin resistance, and it's something that most people can do at home with relative ease, and that would be waist to hip ratio. So it turns out that waist to hip ratio is a relatively good proxy for visceral fat. Visceral fat is fat that's stored around the organs, and it contributes to and drives the development of insulin resistance and inflammation. This metric also has been highly correlated with the risk of future chronic disease states. Now, to measure waist to hip ratio, we of course need two metrics, one being the waist circumference and then the next being the hip circumference. The waist circumference is obtained at the point between the lowest rib and the iliac crest. And I'll put up a diagram to show where that is. And that's divided by the hip circumference, the widest point around the hips. Now, most organizations typically don't have a recommendation for an ideal waist to hip ratio. Instead, what they do is they have an upper limit on waist to hip ratio that classifies as abdominal obesity. And for men, that's anything greater than 0.9. And for women, that's anything greater than 0.85. And that translates to an increased risk of metabolic disease. Now, if waist to hip ratio becomes too much of a hassle, there are other very good metrics that track closely with the performance of waist to hip ratio, one of them being simply waist circumference, and that can be used to track changes over time. And the other would be waist to height ratio, being less than 0.5. In other words, a person's waist should be less than half of that person's height. Now, the next test we'll talk about that relates to insulin resistance is magnesium. In one of our last episodes, we went over the relationship between low magnesium and insulin resistance, and it also turns out that supplementing with magnesium in some people can improve insulin sensitivity. There is also some plausible mechanisms between magnesium and blood pressure. The effect sizes when people supplement with magnesium on blood pressure improvements are very small, anywhere between 2 to 5 milligrams of mercury. So it's not something that we can hang our hats on, but at least there are plausible mechanisms for a relationship between magnesium and blood pressure. We'll go over blood pressure in detail mechanistically in our next episode on cardiovascular prevention, because there's some really fascinating data and mechanisms on the way that metabolic dysfunction raises blood pressure and how it can be reversible. The next group of tests that I'm including are tests relating to kidney function. And the reason I'm including these in the episode is that I have patients come to me who are relatively asymptomatic, and every once in a while you find something really off about their kidney function. There are enough hereditary kidney disorders out there and autoimmune conditions that affect kidney function that I thought it was worth mentioning these. It's not common for a young person to find signs of kidney dysfunction at a young age. That tends to be more downstream of chronic disease effects, but it's worth mentioning, especially for someone who would have kidney disease running in their family or other risk factors like diabetes or high blood pressure, something that you want to make sure that is covered. Now, the first kidney test that I'll mention is creatinine. Many people are probably familiar with this test. It's the go-to test at most doctors in the US and across the country. And creatinine is used, in addition to age and demographic features, to come up with what's called a GFR, or a glomerular filtration rate. This basically measures the amount of volume that the kidney is filtering per unit time. But there are some limitations to creatinine, specifically on muscle mass, creatine use, and hydration status. Specifically, if someone has a lot of muscle mass, creatinine can be falsely elevated. If someone has very little muscle mass, like sarcopenia, creatinine can be reduced. Creatine can falsely increase creatinine, leading to a suppressed GFR, and different dietary patterns can also affect it. It's a good starting place and it's a good test, but in order to get a more accurate view of the actual GFR that someone has, you can combine another test, and that would be cystatin C. So cystatin C is not affected by things like muscle mass or creatine use. The nice thing about combining cystatin C along with creatinine into a single formula to estimate the GFR is that this is a more robust way to calculate kidney function when there are confounders present like muscle mass or creatine use. Now, it is important to know that cystatin C can be affected by other confounders like systemic inflammation, thyroid function, glucocorticoid exposure, inflammation, and smoking status. I'll put a link in the description to a calculator that I use to calculate GFR with creatinine and cystatin C. Now, I'm going to bring in two honorable mentions in this video for identifying metabolic dysfunction, because although they aren't common to be abnormal, when they're abnormal, it's something that you really want to know about. The first one is uric acid. It's been known for some time that increases in uric acid are associated with risk of chronic disease, and specifically with elevated blood pressure and cardiovascular disease. Now, it's important to know that the causal relationship of uric acid to certain chronic disease like atherosclerosis is very much still a topic of debate, but there's decent data to suggest that uric acid could have some causal role in various disease states. And uric acid is also importantly linked with metabolic syndrome. For every 1 milligram per deciliter increase in uric acid, the risk of metabolic syndrome goes up by about 30%. There's also some evidence that in some populations, lowering uric acid could be related to improvements in blood pressure. There are also some trials with decent evidence showing that decreasing uric acid in the serum with drugs like allopurinol can result in better blood pressure or lower blood pressure in some populations. There are some really interesting mechanisms behind this. One of them being that when we eat high sugar content or high fructose content, that fructose has to be metabolized in the liver in a way that spends energy. And the way that happens is fructose comes into the liver and it gets phosphorylated by an enzyme called fructokinase. That requires a phosphate from ATP, which then creates more AMP, which then gets shipped off to uric acid. And there are some mechanistic links between uric acid and blood pressure involving decreased nitric oxide production. So how would I personally use uric acid from a clinical perspective? Well, if I find that uric acid is high, I would start to think about lifestyle factors like excess fructose intake, and that can be driven by excess sugar or high fructose corn syrup intake. I would decrease that. I would also look at decreasing things like alcohol intake, and then examining more broadly for risk factors for insulin resistance and metabolic dysfunction or metabolic syndrome in making those lifestyle adjustments. Now, for our next group of tests, we're specifically looking at the health of the liver, which is a central governor for metabolism that affects the entire body. And what we're specifically interested in is any ectopic fat deposition occurring within the tissue of the liver called hepatic steatosis. It turns out that a more extreme version of this called NAFLD or non-alcoholic fatty liver disease is one of the fastest growing indications for liver transplants in the US. So again, this is something that most people don't have, but clinically, it's surprising who can look healthy who does have this. So again, this is something that's important to know about, specifically for individuals who may have other metabolic risk factors raising the risk of hepatic steatosis. In past episodes, we've gone over how fructose consumption in excess can drive fatty acid production and deposition within the liver, so we won't cover it too much in detail right here, but there are some signs that someone may have hepatic steatosis, and those would be elevation in liver enzymes on a comprehensive metabolic panel or a liver function panel, specifically ALT or alanine transferase and AST, aspartate transferase. So if someone is noticing that their ALT and or AST are elevated for no other apparent explanation, this is something to look into. In addition, there are imaging-based studies that can be done in someone who is high risk for hepatic steatosis, like ultrasound of the liver and MRI. With that, thanks for listening. If you want to support this channel, the very best way to do that is to hit the subscribe button and the like button. If you're on Spotify and are able to leave a review, it helps the channel to reach more people. So with that, thanks again for listening, and we'll see you next time.